Hi, I'm Dr. Faranak Kamangar, and welcome to the Future of Dermatology Podcast. We're here to talk about the real science behind skin, the medical breakthroughs, the cosmetic innovations, and everything in between.
Well, I am so thrilled for today's episode. Joining me is a leader who's shaping really how our specialty thinks and implements AI, artificial intelligence responsibly, ethically. We have Dr. Ivy Lee, who needs no introduction to this group. She's a California dermatologist. So she's a board certified derm in Los Angeles, and she holds an MD from UCSF and completed her residency at Georgetown. She also has her bachelor's in biology and economics from Stanford University and graduated with honors in healthcare economic policy. What I love about everything you've done, Ivy, is that you are just such an expert. And the things that I think are your experience and what is so pertinent, what we're going to talk about, is that you have been on the AAD Augmented Intelligence Committee and Telemedicine Task Force. You're currently leading the dermatology group at the WHO's AI for Health Initiative, a member of the AMA Specialty Society AI Collaborative, and the FDA Digital Health Network. So thank you so much for joining us to have this really important conversation about how we ethically bring AI into, because AI is into the clinical space. Everyone's just brought it in. It's forced itself in, and, kind of how do we approach it? So thank you so much for joining.
Thank you so much, Dr. Kamangar, for inviting me and really inviting me to this community that you've created. And it's so inspiring to see kind of how you bridge all these different generations, different interests into a podcast where you're really exposing us to all the different and amazing diverse paths that we can take as dermatologists. So thank you.
Oh, absolutely. I'm so excited for this conversation because it's not one that we have often. We talk about different aspects of AI, but there's kind of deep dives into the ethics and what we should be and shouldn't be doing that you look at very closely that the rest of us aren't getting a privy to. So I would love to hear all of that. Before we start, though, maybe a little bit about the origin story. You have an amazing background. What kind of, and you can start, anywhere in that journey. What took you from health economics to dermatology to all the amazing things you're doing now?
Yeah, I've always been fascinated with decision making. How do we make decisions, always with the assumption that we're making rational decisions, right? And in econ, really, we think about those constraining tenets of limited resources in terms of time, money, information, and then what incentives are we kind of aligning with? And then what are the trade-offs we're making these decisions underneath? So, thinking about costs of direct, indirect opportunity costs, benefits, and the risks, and how do we make those decisions in the setting of uncertainty, which is all of medicine, right? And a lot of life. And so thinking about decision making, it was just a fascinating lens to think about how we make decisions in medicine. And that's always been in the background of my interest in kind of science and healthcare. And I was really lucky early on to have mentors in my career and in my personal life who've given me a lot of liberty to try different things, a lot of support when I fail, and to model those values and virtues that we kind of aspire to and should be our North Star, depending on, what patient populations or what niches and academic interests we want to serve. So with that, I was fascinated with how do we make decisions and how do we allocate resources in terms of healthcare so that we can augment our own capacity. And specifically for me, to think about how can I, as an individual clinician, augment my capacity. So you and I both know that we could work all day, every day, and still not see the number of patients that need to be seen or the patients that want to get in to see us in a timely manner. So how can we use tools that are available, maybe in other aspects of our lives, to extend our care, to extend our expertise, so we can deliver care to more people in a more timely way, and in a much more personalized way. And the opportunity I got to experiment with that was really with telehealth. And I credit Toby Maurer at UCSF for giving me my first job and taking a chance on me, to say, Ivy, how do we use these tools and make them work for the safety net system in urban San Francisco, where there was a lot of uninsured or underinsured patient populations. And then I had Carrie Kaverick out of UPenn, who gave me that same room to experiment in the global setting, and allowed me to participate in her Botswana program, where we could use telehealth to extend care to folks who otherwise faced workforce shortages there. And then was able to then scale and try a different environment through the startup community and partnering with Direct Dermatology, and how can we use telehealth there to expand access to folks who had insurances like Medicaid, which face really long wait times and barriers to care. So from those experiences, really got to learn, okay, it's really important to understand the technology, where it works well, where it doesn't work well, and then how do we align and customize these tools for the communities that they serve, right? For the clinicians that are going to be using these tools, for the patients that are going to use or benefit from these tools. How can we make sure that this is a tool that we shape for the purpose and for the outcome that we hope for? And so it's been really fun to see how we really are needed to add that human lens and that judgment and nuance and contextualization that I think is so important when we think about technology. And just like with your work with Derm GPT, how do we use technology that exists elsewhere, and how do we customize it to make sure that it's really useful, meaningful, and accessible to folks?
Oh my gosh, I love it. That's so many amazing things that you've done, and decision making. I love that you started with that, because that really is at the core of it. And what it made me think of course, there is clinical decision making, and there's so much into that we can think of, and AI has nudged its way into that. Then there's decision making, and what do we do as doctors in the house of medicine, right? Like there's so many fads coming in, and what do we change our core? Are we okay now with some? Because we were always around ethics and not bringing in things that introduce harm. And we have to be very sure about things. Let's say a new medication comes through, we're very skeptical. But then do we drop some of those safeguards? And what's our decision making and risk tolerance there? And then everything you discussed about all the frontline work that you're doing, that is so incredible. You're such a unique human being, because there are many people that sit in a room and talk about products, or maybe the philosophy behind these questions. And then there are others who are on the front line actually doing it and delivering it, and kind of having these very forward thinking avenues, like how do we use telehealth to deliver to Medi-Cal patients in California, and does that work, and is that sustainable? And I think there's probably not that many of you, but I feel like when these technologies are made, to me, it seems like it should be made with people exactly like you, who understand all aspects of it, rather than people just sitting in a room kind of fragmenting it. So from that mind, I'd love to kind of hear your thoughts about how, and you've seen probably so many AI products coming through the committee and different aspects. Like, how do you see the world of, the domain expert being involved? And is that actually happening? I mean, I think we can all agree that's probably a good thing for the domain expert to be involved in the development of this technology, whether it's telehealth, AI. Are you seeing that's actually happening? Is that a little bit fragmented? Are there barriers there? And where could we improve that, as people listening who are the domain experts? We just would love to hear that, a little bit behind that.
I think you and I are so lucky in that we do, live these professional lives where we can kind of zoom in and zoom out. We have one foot in clinical practice, where we can see those pain points, right, in practice, when it is inefficient, or we can see that we can do things better, right? And we also see our patients' pain points in experiencing the U.S. healthcare system. And then we also have another foot in different areas, and whether it's working with developers, whether it is speaking with investor communities on deciding what to fund or what not to fund, or thinking about how we intersect and work with policymakers, right? How do we work with folks who, are like us, learning and trying to curate all this highly evolving AI content, right? And how do we determine slop from quality, right? I think that's something where we're so lucky to be able to intersect all these different communities and collaborate. And I think more and more of our specialty and doctors are willing to collaborate and understand that in order to really improve not only our own personal experience in delivering care, but also the experience of our patients and to improve the efficiency and efficacy of our whole healthcare delivery system, that we really need to, break out of our silos, build those bridges with folks, because there's so much need for improvement that it really takes all of us. Where we're lucky in terms of domain expertise and kind of asserting the importance of that is we've all seen technology built for technology's sake, right? And we see the hype, but then we see the disillusionment when it doesn't get implemented or it's implemented without any oversight. And that's where I think we play such a critical role, actually throughout the AI life cycle of thinking about what are the biggest problems in our specialty and for our patients or for us, right, as clinicians. How do we triage those and match those with developer and funder interest, right? So those are the tools and those are the tasks that AI is kind of built for. And then how do we play a role in terms of what's fundamental to all of this, which is data and data quality, to make sure that it is grounded in truth, right? Truth is so questionable now, right? And we're so lucky that we still have our patients' trust, the trust of our healthcare systems, that we really can ground that at point of care when we're collecting this data. And we know that quality trumps quantity of data for many, for most kind of models and AI tools. And how do we make sure that data is also inclusive and representative of, patient populations, on, healthcare systems that may or may not have the IT resources, right? Or budgets that some academic medical centers may have. How do we make sure that we can make sure that these tools are built for and accessible to different populations, different healthcare systems that maybe serve different geographical regions, different insurer mixes. And I think it's so important for us to be in that product life cycle at all these different points. We're building these tools together to make sure that they are built with the purpose in mind and outcome in mind, and that we're measuring the right things to make sure that we're making a difference. And that they're implemented and integrated into our workflows, because the last thing we need is another kind of inefficient or clunky piece of software, right? We've learned our lessons from the EHR. We have seen the rise of mobile apps that are, plus or minus integrated well, right, in our workflows. So I think there's so much opportunity for those of us and for rising derm trainees to be bilingual in informatics and data science, and thinking about how do we build these tools, how do we shape these tools and implement them in healthcare to really make a difference, where we can bend that cost efficiency and cost effectiveness curve, and make our system work for a greater proportion of the population.
Yeah, no, and I agree. I think we really need to be very involved, and that involves being educated and knowing how to look at the data and analyze it. We get trained in medical school residency on this is how you read a journal article. This is, these are the numbers you look at. You look at the p-value and you look at, the number, and you get a lot of training in evaluating a certain type of data. And I'd love to get your thoughts on, like, for me, I've interfaced with training. I'm not at an academic center, but I've taught a few courses at the UC Davis Medical School, given some lectures to the residents. And my brief overview impression is that these curricula are not embedded in education right now in a very systematic way. And then when I ask the medical students what their concerns are, some of them say, well, we're afraid of maybe losing some cognitive skills if we're using AI early on. So curious if you have any thoughts there, because we know we have to be involved, and we know to be involved, we have to know what we're doing and have some education in it. What's the best way to get this education? Should it be in medical school, or should we let the med students really develop their touch and art of medicine and not be diluted by AI AI, decreasing their cognitive capabilities, and then bringing in through residency. Like where does this fit, and what's the best way for one, the trainees, and then also we have a lot of docs listening who are out of training, but they're like, how do I learn this? Like, what is the best way to learn this knowledge of how to actually evaluate these systems?
Yeah, that's a great question. And there's no great evidence for this. We're all learning together. And I think part of it is figuring out, what's the best way to share the fundamentals of AI with as large of a population as possible in terms of the clinical providers. And oftentimes, it's not only kind of delivering educational content, which you and I have done in multiple different forums, but thinking about what are the fundamentals we need to really teach. What does AI literacy mean? How are AI tools built? And then also then realizing and helping empower people by understanding the same, concepts of curiosity-driven learning, right? Critical analysis and thinking about, is this tool developed with the right data? And then what is the output? And critically thinking again, is this output applicable, right? So the same tools that we have and the same questions we've always asked of any tool, whether it's the dermoscopy, or whether it is confocal microscopy or a new drug, it's, is this the right tool? How do I use this tool? And is this tool's, effect on my patients, appropriate, accurate, and safe? Those are all the same questions that I think are really important. It's teaching that language and the terminology. And I think the goal of a lot of our organized communities like the AAD, the AMA, is to create content in variable formats, whether that is print and CME articles, whether that is through podcasts like this, whether it's through in-person learning, but to have different modalities that people can access at their convenience in their busy lives, which is really important. And then you and I have had conversations about how important it is to not only have those didactics and the formal education, but also give folks a safe sandbox to really experiment and play with these tools. Most of the times we're experimenting with these tools in our personal lives. And then through that experience, figuring out what is a high impact but low risk way to use these tools clinically. And oftentimes in medicine, what we're using these for are either patient educational resources or, creating, marketing content. I think those are easy and safe ways to start practicing these tools and seeing what are the ways that we need to interact with these tools, whether it's through, prompt optimization with large language models, whether it's through grounding, right, with, our own writing or you know, our own human created resources to shape a better output. I think that takes experimentation. And the more comfortable we get with those tools, the more likely we're able to say, okay, this may be helpful here, this may not be helpful here. And as more and more of these AI tools are integrated with our HR systems, I think that's where we can use it in a more personalized and patient-specific way in terms of whether it's clinical decision support, whether it is remote patient monitoring. I think it really does require that we build that AI literacy, marry that with opportunities to build fluency in practice. And then it really then allows us to have creativity in how we apply this to our daily lives, to our practices. And I'm so thankful that you and I are working together on this in terms of creating that community and this kind of body of resources for folks.
Absolutely. No, I love it. And that's such a good point. Just get out there and practice, try things in a safe way. And talking about kind of the safety aspect of it, I know you've spent a lot of time looking at the ethics of different maybe companies or models, and you could speak as little as much about that as any learnings or any trends you've seen. And most importantly for listeners, any major safety guards that we should kind of put in here, things that you think they definitely shouldn't do or should avoid, or things that should give you a little bit of a pause with the model. As I don't know if you've seen any trends where you're like, okay, if you see this, question that, and from that kind of ethical standpoint, safety, medical, legal.
I think as we develop more comfort and ease with these tools, it becomes something that then we could potentially over rely on, right? And we fall into concerns for either sharing information that should not be shared with these tools. So you should never enter personal health and private health information of your patients. When you're using this for your own personal health, there is concern for privacy, right? And what happens to your data, and will that get leaked? Those are really important questions. And I know there are more and more tools from large language models like the Google Personal Health Agent or ChatGPT for Health that are saying that, we can have a private health chat for you, right? If you want to use this. But in terms of clinical decision support and use for patient care, I'm very cautious in terms of that. And I recommend that you don't do that and enter patient-specific information. And it is something where these are evolving, right? So what used to hold true, where a lot of these tools, the large language models in terms of output, used to come with medical disclaimers, and the Stanford dermatology team has kind of followed this over time, that more and more, even though it is offering outputs that seem like diagnoses and treatments, that the disclaimers are no longer there. So I think that these are also evolving, but to always be skeptical and think, is this something where, again, my privacy and my security is going to be preserved? And then how accurate or applicable are these tools to me for my use case? And so this critical analysis that is necessary is so important. And that's something that we worry about in terms of, as we use these tools, are we going to become more de-skilled in this way, right? And is there a greater need for us to then either double down and upskill our, critical analysis of the outputs? How does this impact our own decision making? So there's a whole, area of human AI collaboration or human computer interaction, what we call metacognition. How do these LLM outputs shape our own thinking, right? We know these tools can be sycophantic, and we know that we as humans have a tendency for confirmation bias. Are we going to be this bi-directional amplification loop, right, in terms of thought? And will this lead to concepts like AI delusions and psychosis, which unfortunately, we've seen, right, in the mental health space. And so because these tools are so quickly evolving and the access, right, to anyone, right, patients, providers, is so easy, this is where it's so important for us as domain experts to be really up to date in how this is used. How do we curate this information? How do we use this tool for good, right, to augment our own learning? I think these tools can be very thoughtful as thought partners as we kind of go through differential diagnoses in our brains, help identify our own blind spots. But how do we make sure that we really still are delivering high quality care that is customized to our patients, right? And I think that's where we will always have value in terms of the healthcare delivery system.
Well, that's great. I love those recommendations. I mean, the number one is very concrete. Don't put private health information. Don't put a person's, date of birth, social security number. Not that we have those anyway, but don't put those in there. That's a very concrete advice because, with these models, they are open, and there are these other ones that are coming out a little bit more closed, or they might, encrypt and decrypt, so on and so forth. But just to be safe, just keep that out of there. There's the concept of, even when you take that out, what is the doctor data and our thought processes? Where is that going? Because that has value. Like a physician's what we're typing and kind of our behaviors and what medications we're talking about and asking about. I mean, there's a lot of value around these things and what's happening to that data. And I love how you touched on the AI and mental health aspect, because we know now clearly with social media as a technology, that's had some mental health impacts with the dopamine hit. People are getting addicted to it, shaping the way people think. To me, AI is like that on steroids. Because it's just, and I think everyone kind of is experiencing that a bit. The AI psychosis is crazy. I've seen this terms coming up more and more in cases of it where really prominent people too, not necessarily a specific, person with a history of mental illness or history of, a specific thing that could lead to psychosis, is it leads them down this path because these models are really meant to keep you happy and keep you continuing to, keep the conversation going. So it is really interesting to think, well, what does that mean in the clinical space, and what we do with that. I recently just saw a patient that, I've had patients come, and I'm sure you have too, that are coming in with more of the because before it used to be the Google search. Now it's, well, ChatGPT told me this. I feel like last week I had the one, maybe my first case of the patient really pushing for a specific thing versus what I was saying. Ended up being fine because it was reasonable. But I was like, oh wow, is this the beginning of? Because initially it was very much like, AI said this. What do you think? And I was like, no, it really sounds like we talked back and forth, and ChatGPT told me it has to be this. So, so I just wonder where that's going to go.
It's been exciting to see kind of how these tools, first with Google and now with these AI tools and large language models, how it is decreased that asymmetry of information, right, in healthcare. And the tough aspect of our jobs is, that how these tools were built were not always grounded in truth, right? And they are a variable validity, right? And we're facing this challenge in society of what is truth. There used to be very clear definitions of truth, and I think in medicine we still have that scientific rigor of what we hold true. Um, but that's definitely not the case in broader society. And it's very humbling, right? And it requires us to teach a little bit of digital literacy and work with our patients on digital literacy as well, of saying, hey, I understand these tools are free, accessible, and they are trained on the corpus of what's on the internet, right? But what's on the corpus of the internet may not be applicable, it may not be true and backed by evidence, and may not be applicable to you. And that's what's the hard part of all of this. Understanding is, like, if we can improve the understanding of how these tools work and understand that this is not magic, right? This is math, and it's a tool that is built by math, right? That there are still ways, if it's trained on poor quality or unrepresentative data, it can still be inaccurate, right? Even though it's free, even though it sounds authoritative, right? There is a huge availability bias in terms of the data that it's created on. And even looking at now more and more evidence that these large language models have the cultural beliefs, right, and values embedded in them. Right. We used to talk about biases in dermatology as kind of thinking about the variability and diversity of skin tone. Thinking about that on a different level for large language models of, this is mostly built upon English speaking, white, Western, or industrialized and rich countries with different cultural beliefs. And so when you think about deploying these tools outside of those settings or in more ethnically or linguistically or culturally diverse communities, these outputs may not be applicable or accurate in those populations. And so a lot of my practice when this comes up, I realize that I am really there to help patients think about, how do we use these tools for their own health or for their own personal lives, understanding that you still need to be that human analyzing that output to say, is this, does this sound right? And is this applicable to me? And was this tool built for what I'm asking it to do? And in terms of when we're curating and looking at medical literature or medical treatment options, gosh, it's great to have those tools, because I know that I'm definitely not up to date with all the literature. There's just so much to learn about. But it's so helpful when we're at point of care with that patient to be like, let's look at, the different treatment categories for your condition and talk through this and have something to point to of JAK inhibitors and say, hey, even though this is the summary, why don't you click on that link and realize, oh, wait, maybe there is evidence, or maybe there's not evidence, or maybe there's not applicable evidence for them. So we're teaching folks to also kind of laterally read as well, to check those resources. And it's fun to do that together as well, where you're kind of, realizing that you're really a partner with these patients as you navigate this deluge of medical information, and how do you sort through the validity or rank kind of the validity and applicability of these tools.
I love it. It's becoming a part of the clinical decision making in the office. And again, it goes back to the more we know about it, the more we can explain the system, the less we're afraid of it when it comes up as a resource, because then you can kind of work through it together and it could be really a resource. Because I think there's studies that have looked at AI plus physician. But yeah, what about that AI plus physician plus patient, in the room? Because that's a whole situation that's coming up, I'm sure, in everyone's clinic rooms, all across. And I love what you mentioned about kind of the truth. The truth part is so underrated right now. I think it's, that's the whole thing. What is the truth with that output? And then of course, every company has marketing. So there is this sort of, okay, well, truth in medicine is somewhat tied to scientifically rigorous, really high impact journals, publications. And to us, like, these have been peer reviewed and there's a rigor there. And then, so I have seen this kind of concept used too by different systems where they'll put those as references. And okay, so you see these logos come up of these super high impact journals, and that's credible. So therefore, we're credible. That's not necessarily a correlation that makes sense. Like, if you know the models, sure, they could read that journal, but 10 people could read one journal article and have a different impression. Same with AI. Doesn't mean that the credibility passes on to the reader or the analyzer. So I'd be curious to see how you've, on the organizations you've been in and ethics, like, how do you uh, teach people about sort of the perception of good AI versus really kind of remove all those little marketing things and really assess it for validity and truth.
It's challenging, right? With
It's so hard.
incentives. And when you're working with different groups, whether it's the developer community, the investor community, they're motivated and driven by different incentives. And I think this is where we as clinicians who collaborate with other communities, we play such a role there in that we represent that North Star of our commitment and our centering decision making on patients, right? What is going to be good for the patient? Good that is shaped by that individual patient, but of what we also know in terms of, you know, population health, right? How can we provide accurate, right, personalized, and then equitable care? And that is in all of our hearts through our medical training, embedded in terms of that North Star. And I think it's critical to have that voice, whether that is listened to or not sometimes in policy settings or in companies. I think we need to be there to voice that. Um, Even when mostly as kind of a representation of, a representative of the patient community, but also because our interests are aligned with theirs in terms of improving their care, and addressing acute health needs, but also helping folks move towards their, longevity and prevention goals as well. And making sure that that is always represented at the table when decisions are I think is really important. And what safe and ethical AI is, I think safety refers to kind of, how these tools are built, what data is used to build them, but then also what data is collected. So how do we know how it actually works in the real world, in this setting, and for those specific patients? Are we collecting and measuring the right metrics, right? Or do we have, mostly correlative proxies that are going to be helpful to measure what we want to measure in terms of clinical outcome, patient reported outcomes, or, cost or efficiency within the system? I think that's where it's really important. And because we are so lucky to be able to provide care on the front lines, that we have that intimate understanding of the need and also the impact. So we're part of that feedback loop of how do we then help shape these tools so that they are more accurate over time, or they're more applicable over time. And if they're not meeting the threshold for us to trust it, or for our patients to trust it, how can we help them get there? And then there are also times where we realize this is not really serving the need, or it's not accurately measuring or shaping the care we want to deliver. And that's important to know too. And it's better to know early on in a safe pilot before it is implemented on a large scale. And I think, again, involving physicians, not only in the development, but also in the implementation and surveillance of these tools is so important. And that's really a part of responsible governance.
Yeah, no, that's fantastic. And I think it goes to the core of, we have these really strong critical thinking skills we've formed over education, and we shouldn't decrease those here. There shouldn't be the sense of like, oh, well, the AI probably knows more than me, so I'm going to lose some of that critical thinking, in addition to the cognitive thinking and that decision making and all of that we want to keep, as attuned as we've ever had. But we want to be kind of critical and really, analyze things. And we're so lucky as dermatologists to have you and colleagues like you who are doing some of this work for us, because everyone's busy in clinic and running around. So we really look forward to, hearing the guidance of what we should be doing, because you are at the forefront and seeing, how all these conversations are happening. And of course, we've kind of just reached the top of these conversations, but there's so much more to be discussed here. And like you said, I'm so glad we're forming these communities. Little plug too, we'll be talking more about this at SF Derm in August in Palo Alto. So I'm just so happy for these conversations to happen. At the end of the podcast, we always ask about, because it's the Future of Dermatology podcast, we always ask what we're excited about for the future. But before that, anything we missed, any one or two last tips we should tell dermatologists to know about AI that we haven't covered?
I think the take-home point is that this is not magic, right? This is a tool that we have so much power and potential to shape. And all of us have the capacity to learn this. And in doing so, we can really work smarter and hopefully not longer and harder, and do more for our patients and the patient communities. So I do think, the goal of what a lot of the work that the AED and AMA has done is, how do we help empower clinicians so that they can be champions for thoughtful and ethical AI integration wherever they practice and for whomever they practice? Because I do think it's so important to diffuse this information and the tools and the opportunities to practice and use these tools so that it can really reach that transformative potential that you hear a lot of hype about, but hasn't translated quite into clinical practice.
Oh, I love those. I love the takeaways. And what, if anything, are you super excited about for the future of AI in dermatology?
Gosh, it's the young residents. It's so exciting. I think they are, because of their digital natives, right? They are already so fluent in how to use these tools, which is exciting because you see curiosity, right, matched with opportunity. And with that, I think it really is infectious, and it really accelerates, right, the progress that we can make. And I also believe in the generosity of those in our specialty, generosity in terms of collaborating, on projects, on initiatives, on QI, pilots, where we can try out these tools in a safe way, and then the generosity in sharing the results. And I think that's very exciting to see, and it's very inspiring for an old dermatologist like me. So.
No, we're young. No one will ever know how old dermatologists are. That's the other.
That's right.
That's the other forever truth. Oh, that's fantastic. I'm so excited to have these conversations. We're going to be continuing these conversations in different formats with all of our colleagues. So it really is just kind of the beginning of it. But I love the work that you're doing, the AED is doing, in just democratizing these skill sets and these concepts of let's stay critical, make sure these tools are helping us, not harming us. And it's so important to kind of have all these guardrails. But thank you so much, Ivy, for joining us today. I'm so excited to hear more and more about this over the year.
And I look forward to collaborating in the future.
And August 2026, that'll be your next. Come to Palo Alto, everyone. You'll hear more. Hey, thanks so much.
Thanks for joining us today on the Future of Dermatology podcast. If you enjoyed learning about the science behind skin, make sure to subscribe, and we'll see you next time. As a reminder, this podcast is for educational purposes only, not for medical advice. Always consult your healthcare provider.